Levodopa Equivalent Daily Dosage. What is it? How does it help to standardize the comparison of Parkinson's disease treatment across the globe? And are there differences in Parkinson's disease treatment patterns in different countries, ethnicity, or based upon duration of symptoms? We'll try to look into this based upon this multi-center study, which has been done, including 6 countries with 10 centers spanning continents. So this article has already been published in Movement Disorders in Clinical Practice, and people can read it from there if further details are required. Parkinson's disease treatment. When we look into Parkinson's disease treatment includes multiple options. This is one degenerative disease with lot of symptomatic treatments, which includes levodopa, dopamine agonists, anticholinergics, MAO-B inhibitors, and advanced therapies such as apomorphine pump therapies, IGLI pump therapies, subcutaneous pumps, inhalers, and surgical therapies such as classical lesioning, DBS, MR-guided functional ultrasound lesioning, and now the newer developments including pharmacogenomics-based therapies or disease-modifying therapies are coming into role. The question what comes is, even though all these therapies are available, they are not spread across the globe similarly. It may be related to availability of these therapies, cultural acceptances in some of the situations, insurance coverages, government regulations, cost of the therapies, genetic predispositions and tolerability of some of the therapies, and treating doctor preferences. So given this variability of all, which is multifactorial in regions, there is some type of a global standardization is required, which can help in cross-compare the therapies across the globe, and also need to understand what is the effect of newer therapies overall and what is the role of interventions. In this aspect, a concept called as levodopa daily equivalent dosage has been proposed. So what is levodopa equivalent daily dosage? How is it calculated, and how it tries to bring together different therapies under single umbrella of calculation? To understand these things, Tomlinson et al. In 2010 suggested a systematic review of all the medications available up to that point of time and gave a guidelines. He used different medications and suggested that what is the conversion factor to be utilized to convert them into what would be the actual levodopa dosage equivalent of that. It included most of the therapies available till then, but not all. For example, it didn't include anticholinergics in one of the therapies down there. However, after that, it has become standard to accept that levodopa equivalent daily dosages is a way to cross-compare among different subset of patients where therapy may not be standard. Down the time, in about last 1 decade, newer medications have come into role, and there was a requirement to have an update in this levodopa equivalent daily dosages. Jost et al. In 2023 proposed a newer updated systematic equivalence study, which included newer therapies and also tried to give conversions for the missed medications. So, which is an updated thing. The question comes is how much is the updated therapy gives a difference, and how each one of those therapies make a difference, or understanding of levodopa equivalent dosages make a difference for understanding for the management of Parkinson's disease. This whole slide shows different therapies which are being utilized for management of Parkinson's disease. The medications in the color box yellow indicate which are already been proposed by Tomlinson et al. And those with the blue or the bluish green color boxes are the one which Jost has added up to the existing Tomlinson's proposal. And each of these medications have a conversion factor in front of them. So those conversions, for example, levodopa 1 milligram is equivalent to the 1 milligram of levodopa equivalent daily dosages. So this is how each one of these conversions are taken up for each of these medications, and they are converted into a levodopa equivalent daily dosages. I'm not going to go in detail about how each one of these are converted because there are some small nuances. For example, the asterisks which I have put down, where the conversion factors do apply based upon how they are affecting or in conjugation with other medications what being utilized. I will recommend to read both Tomlinson's et al. Or if not, at least Joss et al., which is an updated versions to understand all these nuances in converting and understanding this levodopa equivalent daily dosages for calculation of standardization of treatment of Parkinson disease patients. So understanding those things, what the study did was we wanted to look into how LEDD patterns across changed, varied across different geographic and ethnic populations. We wanted to look into demographic of and treating pattern differences based upon LEDD. Is there a difference between these LEDD methods? Means the old and the new, how much differences do they pick up? What new information does the newer LEDD captures? This is the primary goals what we started to look into it. Ethnic differences, geographical pattern differences, and dosage differences. So what does our study reflect? If you look into the world population as of now in 2024, an approximate about 8.1 billion population is there. And our study covers up the countries, which includes 6 countries and 2 continents, which includes India, Sri Lanka, Nepal, Bangladesh from South Asia, Thailand from Southeast Asia, and Canada from North America. If you look into all the population put about these 6 countries, which almost represent about 3.25 billion population, almost like about 40% of the global Parkinson disease patient being treated, and a general perspective view of how much is an impact here, what we are looking into it. The study included about 2,943 subjects which included predominantly Parkinson disease patients, which included around 2,577 people with Parkinson disease. The mean age at onset of Parkinson disease in this cohort was around 56 years, and the mean duration of symptoms was around 97 months, means roughly around 8 years. So with such a big impact of population, we wanted to look into what has happened in each one of these countries. This big chart table shows us how many patients were recruited from each of the countries, what are the gender composition, age at onset of Parkinson disease in each one of these countries, duration of symptoms, stages of Parkinson disease, how many people had dyskinesias, and then the LED calculations. You can see that in both the studies, in all the countries, overall, the total daily equivalent of levodopa equivalent was 597 milligrams in Tomlinson et al. And 609 milligrams in Joss et al. This difference was significant enough to make a difference between both these comparisons, what we are looking into it. What you can also say that the age of onset of Parkinson disease varied across the countries, with India having the youngest age at onset of Parkinson disease, which is around 53 years. We looked into what were the common medications prescribed at the time of final analysis. If most of the people, you can see levodopa was the regular, levodopa formulation was the standard and the commonest prescribed medications, followed by other medications. Usually, most of the newer medications were very few utilized, and among the dopamine agonists, pramipexole was the commonest, followed by ropinirole. Advanced therapies were limited, and anticholinergic, especially trihexyphenidyl, was commonly used, especially in South Asian countries. So, what does the LEDD patterns in this whole cohort is showing to us? If you look into it, there has been a variable age of onset in different geographical territories, with Asians having the younger age of onset of Parkinson disease as compared to North Americans, with India having the youngest age of onset, which was statistically significant. There has been a variable levodopa equivalent daily dosages across countries, means the dosages was not same. In Asia, the you can look at the JOPD et al. Based levodopa equivalent dosages was around 642 milligrams, as against North America was around 562 milligrams. And pure levodopa dosages in Asians was around 507 milligrams, as against 484 milligrams in North America. You can also see that there is significant variation of non-levodopa component across the countries. Non-levodopa means people taking medications which does not have levodopa. It may be dopamine agonist, anticholinergics, and others. Means people in Asia try to use non-levodopa components more commonly. The bar chart shows the average LEDD in different countries. And what you can see that Thailand and India are having a high dosages of LEDDs as against other countries which participated in this study. We also looked into, did LEDD patterns change based upon age at onset of Parkinson disease? We all know that juvenile onset Parkinson disease, those who have onset with less than 21 years at the onset of symptoms, early onset Parkinson's disease between 21 to 50 years, and regular onset Parkinson disease, who have onset of Parkinson disease more than 50 years. We compared these subset of patients to look into what are the differences. What we could notice that the LEDD dosage was highest in early onset Parkinson disease. Means people who had onset of Parkinson disease between 21 to 50 years ended up with higher dosages of LEDD as against the juvenile onset Parkinson disease or the regular onset Parkinson disease. What you could also notice was these dosages were significant enough, and these patients, especially in the early onset Parkinson disease, also had higher dosages of non-levodopa component of LEDD as against juvenile and regular onset Parkinson disease. And all these values were statistically significant. This chart shows you the highlights of those differences with the duration of symptoms when dyskinesias were noticed, the Jost and Tomlinson et al. LED dosages, and non-levodopa component in this subset of patients, indicating the early onset Parkinson disease are more predisposed to taking higher medications, probably related to their work or requirements. We also looked up, is there a gender-based differences in outcome of this treatment? When we looked into LEDD, there was no differences at age at onset, duration of symptoms, in or non-levodopa equivalent dosages in male versus female comparisons. However, the overall LEDD dosages, when you looked into it, men took higher LEDD for similar age at onset and duration of symptoms. Probably this could be related to body mass or some other factors which could be playing a role. But overall, men tend to take higher dosage of levodopa equivalent daily dosages as compared to women. We also looked what happens to the levodopa equivalent daily dosages with the duration of symptoms. And we were interested to see among this remained consistent across all the countries. And what we noticed was the levodopa equivalent daily dosage kept on linearly increasing first 8 to 9 years of the disease onset, from the disease onset to the first 8 to 9 years. After that, there's amount of a plateau effect can be seen with some variability. So what we can tell easily is most of the people will tend to have levodopa responsive symptoms with time up to 8 to 9 years of symptoms. After that, the responses get plateaued off, or non-levodopa responsive symptoms starts becoming more prominent, where treatment goals are directed in that direction. We also looked into, is there advanced Parkinson disease? What is the patterns there? Means people who have dyskinesias and people who had underwent surgical interventions. About 34% of the cohort have been documented to have dyskinesias, and after an average duration of 79 months from onset of symptoms. And as expected, those with dyskinesias had significantly higher levodopa equivalent dosages, that is around 756 milligrams, as against other cohort, which were taking around 586 milligrams, which has been statistically very significant. Coming to surgical therapies, about 134 subjects had underwent surgical therapies, predominantly ST and DBS, and a small subset of cohort were GPI, DBS, or listening surgeries. Age at onset in this subcohort of 134 subjects was around 46 years, and total duration of follow-up in these patients was 201 months. What we noticed was the levodopa equivalent daily dosage was significantly higher than rest of the cohort in this patient, that is around 761 milligrams. And even we also noticed that the difference was significant between Tomlinson criteria and JOST criteria. That is 716 milligrams in Tomlinson's criteria and 761 milligrams in JOST criteria, indicating the newer therapies, newer molecules are commonly being used for people who have underwent surgical therapies. So all this based upon these findings, what are the key takeaway understanding points here are: one, what we can tell is based upon geographical variability, availability, and other factors which limit the access of therapies, LEDD is a better way to compare Parkinson's disease patients across the globe to come more geographical disparities. Two, the newer LEDD calculation criteria is more inclusive and values differ significantly with inclusion of current treatment options in comparison to previous versions. So over last 15 years, probably, what we can tell that the treatment modules have changed, and it's very important when we look into it, all these criteria are taken up for cross comparisons. 3. LEDD dosages differ across different geographical territories. It may be related to genetic disparities and treatment practices. LEDD shows a linear relationship in regards to duration of symptoms across the regions, and usually a linear increase is noticed up to the first 8 to 9 years of disease, and after that there's a plateau effect which is noticed. 5. Non-levodopa components are more in Thailand, which is around 234 milligrams, India 169 milligrams, as against other countries, which was mostly less than 100 milligrams, indicating prescribing patterns and availability patterns. Number 6, early onset Parkinson's disease, that is those between 21 to 50 years, tend to be on higher LEDD and non-levodopa component as against juvenile onset and regular onset Parkinson's disease, probably indicating higher expectation and pushing the boundaries in working professional groups. Anxiety in relation to use of levodopa could also be a factor for having non-levodopa component higher in this group. And finally, post-surgical patients were on significantly higher LEDD and non-levodopa components and could be related to longer duration of Parkinson's disease or higher expectations. These patients probably also are pushing the boundaries to get better benefits as against standard expectations, where we are taught about that there's a dramatic drop in levodopa, which probably holds good during the initial phase of the post-surgical phase, but after that there has been a consistent increase, which matches with other publications in the globe. Thank you. Thanks a lot. This article can be read, can be accessed by scanning this QR code available here, or if anything else is there, please don't hesitate to contact us. Thank you.